Great. Hi, everyone, and welcome to our final Monash Addiction Research Centre webinar for the year. Today, we're really excited to be talking about drug checking services in Australia and reflections on what really is a rapidly evolving practice or practices. We have three fantastic panellists today, Anna Olsen, Bronwyn, Hendry, and John Fitzgerald. I'll introduce them as we go. But before we get going, I'd like to acknowledge the traditional owners on the lands on which we're all meeting today from different places in Australia. I'm on the lands of the people of the Kulin Nations, and I pay my respects to their elders past and present. So just to get started, I'd like to firstly introduce Associate Professor Anna Olsen. She is an experienced qualitative and mixed methods researcher in the field of public health with a particular interest in marginalised populations. She leads a group of researchers who've been evaluating CanTEST, Australia's first fixed site drug checking service in Canberra. I know she has a long history with this topic as well. So I'm going to hand over to Anna to give us firstly a little bit of an introduction about what drug checking is and what we're talking about today.
Thanks very much, Suzi. Nice to see you and John. I'm looking forward to seeing Bronwyn, and thanks very much for having me. I'm coming from Ngunnawal Ngambri country in Canberra, and I'd like to acknowledge the traditional owners of the lands on which I'm coming in from, and there are also the owners of the land on which CanTEST, Australia's first fixed site drug checking trial, is underway. So, as Suzi said, my job is just to give a really quick, broad overview of what drug checking is and sort of where it comes from and a bit of its history. So drug checking, it's sometimes called drug checking, or in Australian history, it started off being called pill testing, so it's often called pill testing as well, is essentially a harm reduction service. In essence, what its main role is to do chemical analyses of contents of drugs and to notify people of what's in those substances. Generally, these services also offer harm reduction advice on the safer use of drugs, and often these services are linked into a warning system to notify health or the public. So there's lots of different types of models. So drug checking seems like this fairly new thing in Australia, but it's actually been around for decades, and there's lots of different ways you can provide drug checking in a community. So it can be like at an event, and sometimes that can be front of house where people come in and they present their drugs, or it could be back of house, and that's where drugs that have been confiscated or dropped or lost are tested. There are mobile services, there are fixed sites, which is what's being trialled in Australia, and there's also postal services available in Europe. So we haven't had a global review on drug checking services for quite a few years now, waiting for Monica Barrett to update hers. But at last count, there were 31 services, and there's way more now, lots more. Drug checking services have been available in some European cities for decades. More recently, the Americas, New Zealand and Australia have joined in and started providing drug checking services. And that in North America in particular, it's a contamination of the drug market with fentanyl that's really driven drug checking services in Canada and the US. So why do we do it? Like, why is it offered? As many of you would know, illicit drugs commonly contain a wide variety of contaminating substances, and there's also a large number of psychoactive substances, new psychoactive substances coming on the market all the time, and also, as I mentioned, the high potency synthetic opioids, which are rife in North America at the moment. Now, people who use drugs have really very little way of knowing whether there are impurities in the drugs or the strength of the substance. There are reagent kits, which are home testing kits that are available, but they're not very sensitive and not very reliable. So at the moment, we don't know much about the drug market apart from what's seized by police. So Australia is really interested, and there's lots of jurisdictions in Australia that are looking into drug checking at the moment. That's not new. It's been talked about for 20 odd years now. There's been a big push, but the recent rise of deaths of young people at music festivals in that summer of around 2019 summer, including the rise of festival patrons seeking medical assistance, has really kind of bolstered the efforts to get drug checking in Australia. We're also seeing some fentanyl in seized heroin and cocaine, which is very worrying, and just broadly our harm reduction efforts. And when I say harm reduction efforts, what do I mean? The overall intention of drug checking is to minimise the risk of injury, death and other harms, including like drug interactions, distress and so on, from by telling people what with reasonable certainty what substances they are bringing in. At the individual level, reporting these contents of drugs and providing information from professionals is considered a harm reduction intervention. At a population level, drug checking services also allow us to aggregate data from drug samples and provide insights into trends into the unregulated drug supply, which is where John comes in.
Unmute. Thanks, Anna, for that overview. I guess you've laid out some fairly concerning patterns in terms of contaminants in drugs. Can you comment on what you know that consumers are doing right now to test their substances, given that we don't have widely available services at this point?
Yeah, well, we know from some of our national surveys that people are reporting using reagent kits, which are the home test kits, which you know, they're better than nothing, but you know, they don't provide you with a lot of certainty in terms of the contents of your drugs, and they vary a lot in their quality as well. You know, what we can take away from that, though, is that there is a desire and a need and a want from people who use drugs to test their substances. So being able to provide them with more quality results in terms of testing those substances, you know, there is a market for it in Australia. People will use those services, and that's certainly what's been found in CanTEST.
Great. So there is a real interest in this from people who are using drugs. Now I'd like to move over to Bronwyn Hendry. Bronwyn is the CEO of Directions Health, who are the lead organisation in the consortium who are operating CanTEST, the first fixed site drug checking facility in Australia, which is completing a 6-month trial in Canberra in partnership with Pill Testing Australia and the Canberra Alliance for Harm Minimisation and Advocacy. So thank you so much for joining us, Bronwyn, today. Can you perhaps give us an overview of how the CanTEST service operates, what a typical visit to the service involves, and following on from that, what was the development process like? What were some of the, I guess, key considerations and challenges, and how you work through that process? Now, there's a lot in that question, but I'll hand over to you.
Okay, thanks, Suzanne, and hi, everyone. Yes, we feel very privileged to be able to offer the first fixed site drug checking, or really consistent drug checking anywhere in Australia. The service is operating twice a week. One session is in business hours on a Thursday between 10 a.m. and 1 p.m. and the other session is on a Friday evening between 6 p.m. and 9 p.m. And that was designed to be convenient for different population groups who might access the service. So when somebody presents to CanTEST, they come in the door, they're asked to put their phone or any other device which may be able to record or take photographs in a locker, and they're given the key to that. And so they don't have that with them for the entirety of their visit. Then they're asked what they would like to do, whether they'd like to have drugs tested or see the health professional that's on, the nurse, or whether really they're just wanting to find out more about the process and maybe consider coming as a client on another occasion. So if they say they'd like to have drugs tested, then they're asked to sign a waiver. And that waiver just outlines the limitations of drug testing. So obviously we can't give them 100% guarantee of what's in the substance they're testing. We can't tell them how they're going to react personally to that, and we can't tell them whether it's safe. And certainly, you know, there'll be all sorts of things that contribute to their own personal risk profile around that. They do sign their name and or put their name down and sign, but we're not asking for ID, and that information is kept completely separate from any of the other data collected around CanTEST. So they're completely anonymous in that sense for subsequent engagement with the service. So once they've signed the waiver, then they're assessed for eligibility as an individual accessing the service, and also whether the substance they're wanting tested is something that we can provide testing for. The eligibility really is just around, are they able to understand the information provided? So there could be occasions where people are either so intoxicated or otherwise so cognitively impaired that they are unable to understand the information we're giving them, but that hasn't really happened. So it's just a safeguard that we have in place. Then they're asked to provide a code name, and that if they consistently provide the same code name, and it's just anything of their choice, then we can link their future visits with the service and get some more information for that, and it saves them answering some of the questions that obviously don't change from one visit to the next. Then they undertake a pre-test survey, so a questionnaire that asks them a series of questions about the substance they're having tested, what their expectations are, how do they find that, the information about it, and what harm minimisation strategies they might be considering, what their likelihood is of consuming it, a whole range of tests along those lines. Then they're taken into the testing room and they provide a very small sample of the substance, like just grains of it really. It may be a scraping from a peel or a crystal or powder, whatever or could even be some oil-based liquids or whatever. So the testing's conducted. All substances are tested using the FTIR, but they may also elect for UPLC, and we can give them information about the purity on the 10 most common substances that the UPLC is set up to provide, as well as fentanyl testing if that's indicated for the substance that they've got. Excuse me. Once those tests are complete, then they're given the results, and the analysts give the results, but also in the presence of a peer educator or an AOD counsellor, who will then take them through what some of the implications might be for that person, give the person a chance to ask questions, and really provide a whole range of harm minimisation strategies. Now, if it's something that is unexpected for them and certainly not what they're seeking, they may discard the substance, and we've had quite a few discards. And then they're provided also overdose prevention and naloxone if that's relevant for them. Then they complete a post-test survey. Sorry. And that contains questions about, now they've got the results, what are their intentions really? Have they changed from previously? What are some of the harm minimisation strategies they might employ? Would they like to participate in a post-test survey as part of the evaluation and or an interview? So they can provide the contact details for that and then be followed up by Anna's team. They may also elect to see the nurse, or they may only be coming to see the nurse and receive a range of health interventions that are possible. So some people do both. Not many people come in just to see the nurse, but we've certainly had, that's been a really helpful aspect of the service, particularly when people are using steroids, for example, and maybe not very experienced with that. They have medical conditions that they feel might be relevant for whatever they're using, or if they've just got other health issues that they want to discuss that are completely separate from their drug use. So that's it really. We're exploring at the moment providing some follow-up results for people if the tests are inconclusive, and GCMS is conducted by ANU or ATGAL, and then we can try and provide a bit more information to people that wasn't available at the time of their visit.
Great. So interesting. Obviously, a lot of thought has gone into this. I have a lot of questions, and I imagine people in the audience might have questions as well. If you do have questions, feel free to pop them in the Q&A box. We will have time for questions at the end. Before I go to John, though, I did have one quick question just about the mobile phones. Is that around privacy, to not have people recording in the space?
Absolutely, yes. It's really, we need to respect everyone's privacy, and we certainly don't want images of people going over social media or conversations recorded. Quite a small space, so really you can't ensure privacy unless people, and people are very happy with that, although they struggle with not having their phone, as you can imagine, particularly when they're waiting. So there's lots of little toys and things for people to hold and play with, as opposed to using their phone, and actually conversations to be had with people as well. So that's really useful. Did you want me to go into the developmental process and the challenges now?
Yeah, you've touched on some of the, I guess, things that the service has considered in terms of timing of access and those kinds of things. If there's anything else that's key around the development process, or we can come back to questions at the end, but I guess being the first fixed site service, I imagine there was a lot of thought into how to operate that during the pilot and how to make it accessible for people.
Oh, absolutely. I mean, all the protocols that needed developing took a significant amount of time and resources, and people, I imagine, who set up fixed site services or even festivals subsequent to this can benefit from some of that work. We've got a consortium model, as you outlined in the beginning, and any consortium model, as people will know, requires quite a lot of resource put into ensuring all partners feel that they are equally represented and everybody's views are heard. And everyone has different expertise in the consortium, so they come from different perspectives, and so that's been quite a lengthy process in terms of agreeing all the protocols and processes and subsequent actions that we might be considering since establishing the service. But it also means, I think, that because there are so many different perspectives, that the result is probably more robust than it would be if it was just developed by ourselves or a single agency. We also have staff from CAMA, as well as our own staff and analysts that are overseen by the ANU School of Chemistry. So, you know, making sure all the staff work together and are supported to work really well as a team requires more resources than, you know, if you just had a single agency staffing in there. So that's something that we really pay a lot of attention to, and that's been fantastic. Everyone has worked really well as a team. Other challenges really include the level of scrutiny the service has been under. So it's perfectly understandable that the government and others are really paying a lot of attention to the detail and really want this to work well and don't want any controversy, I guess, you know, and that's better for all of us. That's better for drug policy in Australia and a whole range of other things. But that obviously complicates the process quite a bit. Ensuring we're really consistent in our public messaging when everyone comes from different perspectives is something that requires a lot of coordination. And the other thing, I guess, or the other couple of things really are insurance is not that easy for people to get. And whilst we were able to arrange that prior to establishing the service, that's becoming increasingly difficult for a whole range of services in Australia, and I know other places have really struggled with that, and certainly that's impacted on festivals, so that's quite a challenge at the moment. And the other thing I think that we probably didn't anticipate was just the sheer amount of administrative work that was required to support the service. And that's across a whole range of things, whether that's reporting or public notifications or social media, or, you know, it just really does require a whole sort of machine behind it, really, to make everything work well at the coal face. So they're just a few of the challenges.
Great. I mean, I imagine you could talk for many hours about the learnings of setting up the service. So hopefully we'll have time to come back to that. I can see there's some questions already. Before we do that, I'll hand over to our third panelist, which is John Fitzgerald, who's an associate professor at the University of Melbourne. So John's recently involved in an early detection and drug monitoring program during the pandemic in partnership with the Victorian Department of Health. So John, can you tell us a little bit about this new monitoring system, the Rapid and Precise Intelligence on Drugs pilot program? I hope I've got that correct, or RAPID for short. What kind of work did you do within the pilot program, and what sort of insights did you uncover in this space?
Yeah, back in 2019, we were doing monitoring of drug residues in music festivals. And I think back then we were quite dissatisfied with the policy environment around the debates around drug checking. And we really wanted to see what we could do within the existing laws around monitoring and providing some kind of information at music festivals around drug consumption. And back then, what we wanted to do was to try and just be pretty forensic in trying to identify who was going to benefit from knowing more about what was being consumed. And there's already like a vast amount of data from drug checking services in Europe around models that provide information to the individual. So this is the drug checking model where the individual gives their sample up and they get information about the drug individually, be it anonymously or not. But what we were looking at is, well, what if we went for what is often referred to as a kind of back of house model, where information is given to the event management. But what we were not interested in is working with police doing a back of house model, where we were interested in collecting information about drug consumption, but giving that information back to the event, where the event could then give information back to patrons about what drugs were being consumed at the event. And this had been done quite a lot in Europe, but it was done as a kind of stepwise progression to get to individualized drug checking. But we kind of hadn't done that to any great extent. Some festivals had done it in Australia. There were a couple of individual festivals who tried to do that, but it was done as a kind of ad hoc thing. So we started doing that in 2019, where we started testing the residues in plastic bags and in little Ziploc bags that people use to carry their drugs around in. And we started doing that at music festivals, and we're getting really great results around what we could identify. And on the basis of that, we then were able to use some really great technology. Gavin Reid and James Yogas and others at the university really had some fantastic methods. And we then approached the health department and said, well, instead of just doing this at music festivals, what if we were able to do this in the community setting? And we did that during COVID. And so what we did was to do this residue testing. Now, this is not a new thing. It's being done in a number of different cities in Europe as well. But effectively, it is a drug checking technique, but albeit in a different kind of way. It's really fully anonymous in the sense that this is effectively picking up rubbish off the ground and testing these empty plastic bags. But it's really important to identify who receives the information and what's done with that information. And that's where it is distinctive and different from individual drug checking services. And so we've been doing that. We've been doing it this year. We did it earlier this year, and you can do it with a range of different technologies, and it can be integrated with other types of data collection systems. So RAPID uses residue testing as one of three other types of data collection systems. Yes, earlier this year, we were still doing some music festivals. During COVID, we did residue testing with used syringes. We also did illicit wastewater analysis, and we've also, partnering with EDNAV, which is monitoring people who attend emergency departments from drug overdoses, is monitoring blood toxicology results. And we integrate those 3 different data sets and report that information back to the health department. We don't work with police, we work very much closely with the health department, and it's funded through the Department of Health. During COVID, we actually provided weekly reports, and we've done 2 6-monthly data collection windows, and we've only just in the last month completed our second 6-month data collection window. So what it does is effectively we use drug checking as one technique for collecting data about the illicit drug market. Take-home message is that during lockdown, we found that the market adapted to the fact that our borders closed, and when borders closed, access to heroin dried up, access to a range of different drugs dried up, and the market adapted. We saw new drugs introduced into the market, and we saw people combining drugs in a range of different ways. So effectively, we saw people combining over-the-counter drugs in vastly new and a variety of drug combinations that we'd never ever seen before, to an extent that we'd never ever seen before. And we had very detailed information about how those drug combinations were used, both at a market level, but also at a very low level as well. And of course, it was geographically quite specific. We were sampling across different parts of Melbourne. So that's how we've been using drug checking, not so much at an individual level, at a population level as an early warning system. So in Europe, I've just returned from discussions with the European Monitoring Centre, where they use drug checking services, the harm reduction services that do drug checking. That network is actually feeds their information back to the European Monitoring Centre as a network that feeds into their early warning system. So it doesn't just provide information to the individual, that there is a kind of broader population contribution it makes to population health. And I suppose that's where I sort of come in, is that my interest in this is that there is a kind of another way in which drug checking sort of contributes, is that it's not just at the individual level, but it actually can contribute at a number of different levels, not just at the individual, but it can also contribute at the level of the event, and also at the level of the population as well.
Right. So, John, I think what you've just raised is that, you know, in certain times and certain circumstances, we see massive changes in the drug market. I'm wondering, Anna, if you could talk a little bit about, you know, some of the challenges around drug checking, particularly with these, you know, new emerging substances that, you know, that may or may not be detected during drug testing, and how sharing results can help to mitigate some of that uncertainty that we have in the drug market, particularly for, you know, consumers. Would you be able to talk about that?
Yeah, sure. Thanks, Suzi, and thanks, John. That's a, you know, really nice basis to talk a little bit more around some of what's been developing in Australia in terms of creating like a feedback loop nationally. There's been a lot of work over the past few years around collaborating across all the different states and territories, and thinking about how Australia could create a model in which the various different ways that we collect information about the illicit drug market can feed back into almost kind of a warehouse of work to create population level information about not only what's out there, but what's evolving. what's changing, and also to your point, Suzi, what we don't know as well, because everything's evolving so much. So part of just bouncing also off what Bronwyn was mentioning in terms of the CanTEST fixed site service and how it started off, and how it has pivoted a little bit in its process to be able to deal with unidentifiable substances in the service, and that's that it's as Bronwyn alluded to, it's starting to change its processes where if the substance cannot be identified at CanTEST, there's a discussion with the person, and that sample, that tiny sample that's taken, can be taken off-site and tested both at the chemistry labs at ANU as well as our ACG health analytical labs. So in order to kind of meet the needs of the evolving drug system, drug checking services are, providing information as they can on site, but also broadening the fancy technology that's needed to investigate and discover these new substances by linking to fully set up analytical sites. The complexity in that, and as John alluded to, is how much of that information can be fed back to the individual that brought the substances, and how much can that be fed back to the community. And all those processes are done slightly differently in different places across the world. And in this trial period in the ACT, those processes around community feedback are developing, but certainly the monthly reports that are coming out of CanTEST are providing public information to people around what's in the drug supply in Canberra. There have been also alerts issued from both CanTEST and ACT Health around dangerous substances, or particularly dangerous substances that have been identified. So there's a myriad of ways that it can work, both at the individual level and the population level, and Australia needs to have a bit of a play around and figure out what works in different situations, what we can afford, what different states and territories are willing to put into it, what the political pundits are willing, how far they're willing to go. There's a lot of unknowns in Australia, but there's so many pockets of work in many states and territories that there's a lot of positivity around the potential for a national repository, which is what Penny Hill's working on, of this kind of information.
Yeah, and I've certainly seen some of those alerts coming out through social media from CanTEST, and it is great to see that very quick sharing of information that could be really important from a public health perspective. So I guess from the international literature, we've seen that not everybody has equal sort of access and interest in drug checking. So, for example, we've seen sometimes people who use stimulants don't necessarily feel they have time for drug checking. That was certainly our experience within supervised injecting facilities in Australia, that perhaps it's not necessarily a priority or something that everybody has either the time or the capacity to engage with. And I guess that might be determined in part by how often people are using substances, and so how often they would need to be testing substances, those kind of fairly practical issues. We didn't have a lot of interest in sort of fentanyl testing strips in that environment, for example. I'm wondering, perhaps Bronwyn, and I know you're working very closely with CARMA and people with lived experience, are there populations that are perhaps currently engaging less with drug checking in Australia? And in the context of CanTEST, are you aware of strategies to maybe make it more accessible to particular groups or models that might overcome some of those barriers?
Certainly the majority of people that are using the service would be considered recreational or occasional drug users. And we know there's no true dichotomies, I guess, between different groups of people who use drugs. But generally speaking, people who would be considered dependent, or those injecting, people using injection as their route of administration, have been less likely to use the service. We deliberately wanted a session during business hours so we could encourage people coming to our NSP, which is in the same building, to come and use the service. And some of those people have. Time is a factor, as you've identified. Some people really are just ducking in and ducking out and don't really have a half hour to spare. But the other issue that we're gradually overcoming, I hope, is that people don't want to give up what's often been a very hard one, although minute portion of the substance they have. You know, it's a difficult thing for people to keep themselves in supply if they have a dependency, and the thought of giving up some of that is not a very attractive proposition. I think it may change if we start finding fentanyl derivatives in the opiate supply in particular, but in other drugs as well, which we haven't to date. We do give out fentanyl strips at the NSP, so people do have the opportunity to test for fentanyl if they're coming into the NSP for equipment, but we rarely get a positive result. And as people would know who've used fentanyl strips, they're a little counterintuitive. So sometimes, you know, you can think that it's a positive result when it's actually a negative, and vice versa. So we're very mindful of trying to ensure people can interpret the results correctly. But if fentanyl does creep into the Australian drug market more than it has, I think there'll be more motivation probably for people in particular who are using opiates, but potentially other substances, to have them tested. But with NSPs, anything new is an evolutionary process as well. Like when we first introduced wheel filters, then it took quite a lot of time to convince a lot of people that you don't lose anything of value in that process, that really it's just taking out the things that you don't want rather than some of the things that you do. So we think, you know, people will gradually become a little bit more relaxed and a little bit more receptive to having their drugs tested. And that's probably the same for a lot of recreational drug users as well. You know, we certainly haven't seen everyone in Canberra who's likely to use a drug in the 4 months we've been open. So I think that's a gradual process as well. People feeling comfortable, hearing that others have had a good experience and that it's not going to use too much of what they're thinking about consuming. So yeah, and we've seen a gradual increase over time as well.
Yeah. I mean, it is one of those things, I guess, for people to get used to. I have seen on social media that you've been, I guess, overwhelmed with interest on some days. So it does seem like it is getting out.
Yeah, particularly before a big event like Spilt Milk Festival. It definitely demonstrates what is the need for having pop-up testing at festivals as well, I think.
Yeah. John, if I can go back to you and just thinking about sort of the RAPID program, where do you see things going in terms of, I guess, national drug monitoring and early warning? What are the next steps?
Well, it's unclear what we're going to do with RAPID. We've just had an election here, so we're still waiting for the next parliament to settle in. So we'll wait for that to see what happens. We've had 2 6-month data collection windows, and we're still finishing off a component of RAPID 2.0. We were really, in terms of what we know from RAPID, is that we know it makes a huge contribution. So we processed around 3,000 samples in 6 months. So in terms of volume, we're pretty confident that it can do a lot. We know that it integrates data across a number of different data sets. We know that from the first version of RAPID. So internationally, we know that the model that we use is very similar to the model that the European Monitoring Centre uses. So we know that the discussion nationally, that we know all the bits of an integrated early warning system are there. So whether it's drug checking that's occurring in harm reduction services like we see in Canberra, or whether it's residue testing in Victoria or other types of testing that occur in other jurisdictions, that the contribution of drug checking to early warning systems like RAPID is that I think the real challenge is to create what I'd call a policy narrative to those federally, to say these are the benefits, and to make that story to the people who need to hear it, because the elements of the system are already there, and everyone's been talking about a national early warning system for quite some time. And I think what we've shown in RAPID is that it's very doable. We actually didn't have to change any laws in order to do it, and so it's ready to go, really. So I suppose that's what we were able to prove, is that, you know, really the proof is there, and it's about protecting and valuing the public health, which is what needs to be elevated now. So yeah, that's where I think RAPID is at the moment, is that it's been a great proof to the public. I think the contribution of drug checking to that discussion can't be underestimated. I think drug checking needs to be considered not just as something that provides information to an individual. Really important. That's obviously its primary contribution is to an individual and their choices, but it also has a profound impact at a population level. And I think that line of conversation, that line of argument, we need to really keep that on the table, because it is a profound contribution, not just to people in Canberra, but to the population's national health. And we should all be really thankful for Bronwyn and the team, and to Anna for their contribution that they're doing, because we're all benefiting from their work.
Right. Yeah, it is. And look, it's obviously been a highly politicised topic, and there are some barriers that are a little out of our control, as you just mentioned. Bronwyn, if I can go back to you, CanTEST is a 6-month trial, and we know it's ending soon. Do you have a crystal ball to imagine, you know, whether or not this might become a permanent service, or what the next steps might be there?
I don't have the crystal ball, but certainly we're just about, I think ANU and Anna's team are about to deliver the interim evaluation report, which is looking at the first 3 months of our service. And I think it has been a positive experience for everyone involved. So we're assuming the report will reflect some of those things, but also have some ideas about how we can tweak the service to make it even more responsive to the people that we're providing to. The government certainly hasn't indicated that they have a wish to cease the service after the 6 months trial, but there isn't an appropriation that's currently identified at the moment. So I think they'll wait until they receive the final evaluation report prior to making any long-term decisions. It may be that we get a short-term extension whilst all that's occurring, and then some longer-term decisions are made, but we don't really have any certainty around that. A couple of things I could have mentioned before was that we're seeing increasing use of the service by a couple of different groups. People who use image and performance enhancing drugs in particular. So we're seeing more people coming in with steroids and other substances of that nature. And we've also had occasion where people are purchasing illicit hormonal treatments and coming in to have that tested, so people who may be wishing to transition or use those types of substances. So there's quite a wide range of applications potentially, not just really the illicit drug market that we've been talking about.
Yeah, look, that's a great point. There's an enormous world of, I guess, falsified medicines out there as well, which can really put people's health at risk.
Yes.
So I think we've heard a little bit from John and Bronwyn about what might be next. Anna, maybe as I open up to the whole panel, I can start with you in terms of where you see these services progressing, what the practical next steps might be. I know lots of states are looking on with envy when we see the ACT and the service that you have now. Did you want to comment there?
Yeah, thanks, Suzi. I mean, only to say, and I also don't have a crystal ball. I think there's sort of so many different cogs to the wheel here, what might happen next. But there is a stronger political will than ever to put some funding into these kind of services in Australia. So as John said, whether they are kind of person to person, more individual level services, or more population health surveillance services, or a combination of the two. There's definitely more political will there. And there's certainly some other states and territories which are really on the edge of trialling some drug checking services in different modes. They really are, we're just sort of hold on to your seats as sort of, I would put money on that there will be announcements from at least one other state also in the next 6 months, which is really exciting. So yeah, things are moving. I mean, obviously we've, in recent history, we've also had some very large public inquiries around illicit drug use and harms and deaths related to illicit drug use, particularly focusing on New South Wales here, both of which the outcomes of both of those inquiries suggested that drug checking would be a way to reduce harms to young people who are using drugs at festivals, as well as people who are using methamphetamines and other drugs. So there is a growing amount of will and evidence out there in Australia to increase our focus on these sorts of services.
Great. Now, I've got a couple of questions here from our attendees, so I'm going to go through those, and I've got some questions of my own that maybe we may or may not have time to get to. I guess the first question maybe touches on my question earlier about the removal of mobile phones. I can see that could be taken different ways. It was a query whether or not that's stigmatizing. And I guess, Bronwyn, I know you've worked with CAMA in terms of developing all these policies and procedures. I'd be keen to know about the input of people with lived experience and their thoughts on that issue and how you came to that.
I guess we've had CAMA's input in development of the protocols, but also the responses from all the clients or patrons who've attended the service. And people generally don't object to giving up their mobile phone or their iPad or whatever. And people are really reassured by the fact that their confidentiality won't be breached. I did see that question, and it's not really the same as coming into other drug and alcohol services or primary health service or any other health service for that matter, because you are there because you're carrying an illicit substance generally. So the activity you're engaging in is not currently legal. Thankfully, in the ACT, it will be in around October next year, not a criminal offence to possess a small amount of illicit substances for personal use. But at the moment, it's still an illegal activity. And I think it's reassuring to people, whilst nobody wants to give up their phone, we're all kind of going to have them. It'll be harder when we have them implanted, I guess. Then we'll have to figure out what we do then. Whilst I'm still part with them.
Can I add to that, Bronwyn? My understanding is that some of that focus for CanTEST has been historical, and that's at the two trials that PTA run at Groovin the Moo, so a festival-based testing. There were concerns there around people's privacy, not only from one another, but particularly from media, and there was media trying to put the camera up and snap over the fence and things like that. So whilst there's so much media attention on these particular services at the moment, where anyone can come in, they're low threshold services, anyone can come in. Personally, I think it's a good idea, and it wouldn't surprise me if the need to do that will dissipate in time. But right now, they're just too politically hot, and it is is it is appropriate, even though I do agree that there's some potential stigmatizing aspects to it. Would also be way more stigmatizing if someone's headshot got out.
Absolutely.
Great, thanks for talking through that. I'm sure there have been many rich and robust conversations leading up to all the policies that have been implemented on site. The next question, I think, is one that we were talking about earlier before we came online, is around, I guess, there are different methods of testing that may have, different abilities to pick up things in low quantities. And I guess particularly when we're thinking about fentanyl and fentanyl analogues, some of these things are very potent substances present in very low quantities. I'm just wondering, I know you're using a couple of different methods at CanTEST. How does that address this risk that maybe some methods like FTIR, for example, might not pick up those kind of very low concentrations? Can you talk us through that, Bronwyn?
At the moment, we're using fentanyl strips for that because none of the testing on site can necessarily pick up fentanyl in very low quantities. So that's an added test that we offer people where fentanyl might be present. If the substance goes off site for further, more sophisticated testing, then obviously we can get the results from that as well. But really, what we're using at the moment is strips.
And is part of the issue there the amount of time it takes to do maybe some of those more sensitive tests versus what you can do quickly on site, or?
No, not really. I mean, the FTIR is very quick. The UPLC is around 10 to 15 minutes, but most people are keen to have that because people are interested in the purity of their substance, and it also can verify things that maybe the FTR has a low confidence about or find other things. But no, it's not really to do with time. It's just to do with the sensitivity of the testing for really small quantities, which fentanyl tends to be. Yeah.
Right, or even when we're talking about carfentanil again.
Oh, absolutely. That's even,
yeah,
smaller. So, yeah.
Yeah. So the next question is, I guess, one of scalability of drug testing. Again, this is something that I've been involved in a lot of conversations around, particularly around that equity issue in terms of making it accessible to people. The question here is wondering whether pharmacists might be able to help with this, but maybe I can turn this into a more general comment for the panel in terms of maybe pharmacy settings, but also what other settings have you seen, or could you imagine these kinds of services going into to try and make it more accessible?
Is that to me?
Look, if you've got a comment, Bronwyn, otherwise I can hand to Anna and John as well, just thinking about, other models we might think about.
Well, I could quickly say, I mean, I won't take long, but certainly needle syringe programs could benefit if they were able to implement testing, as well as injecting centres. Clearly, it would be a valuable addition to their suite of services. But Anna or John, do you have?
I'll be super quick, John. I was just going to say, yes, I think it's a great question. I think scalability is absolutely an issue to think about because, CanTEST is, as Bronwyn described, a wonderful holistic service, but, it takes a lot of staff to offer that range of services. And that's not something that's going to be possible in, kind of rural areas, smaller areas where with less resourcing. So being, thinking about the lots of different ways that you can improve people's access to drug testing is something that we really need to think about. And certainly to John's point, some of the scalability issues are resolved by a back of house population level quite type testing where you can get more population level data, which can be in a good system can be integrated really well with harm reduction information that people can take on board and link with their own drug use. So yeah, there's lots of different ways that we could think about scalability, and I agree it's an issue.
Great, thank you. And John, did you have a comment there?
Yeah, I think scalability is really, there is a dollar sign attached to that question. And, if you're willing to put a Dart MS system, which is what we've got at Melbourne Uni, they're relatively expensive. But if you put one in, then you can turn your tests around in less than 5 minutes, and it's high resolution. But they cost more, and that's the trade-off. Yes, you will be able to do high resolution testing, and you would be able to do it on site, and you would do it in a very timely manner, but it will cost more. But the issue is that it's what is it that you're valuing? At the moment, you're requiring patients to indemnify the tester. I'm not sure at the moment, because is that what's happening at the moment? Like, is that like, if it, I might have misunderstood. Is that
Not
the case?
really. We've got insurance for our testers and all our staff, and medical indemnity, and so no, we're not. We're just getting people to sign the waiver because, one, it demonstrates that we've got robust processes that mean that we can demonstrate we've explained to people the limitations of drug testing. So I think it's just good process. It's not that we're requiring people to indemnify the tester. We could have regulatory environment where people aren't able to sue, for example, as they have in New Zealand. So that's another way of dealing with the issue of insurance, that that really people who are coming to the service accept the limitations and don't have a legal recourse when things might go wrong. So there's a whole raft of ways we could actually deal with those issues.
My sense is that there's a kind of discussion about this that is quite unusual, that we wouldn't be having if this was a renal service, or if this was a pathology service offered to managing another health condition. And these are kind of unusual questions that I'm not sure are wholly justified. And I think there is a kind of, there's a bit of a lightning rod because of the moral history around our arena. And yes, there is a pragmatism that we need to deal with a number of these questions, that we just can't say, well, that's not fair. We have to deal with these questions.
True.
And but I also, having been a board director at a hospital, I always go back to the issue that drug and alcohol services are services that should be one of the many services that we run within our health services. And there are specificities of drug and alcohol, but I always like to consider them as being, wouldn't it be interesting if we asked the same questions of our drug and alcohol services that we ask of our other mainstream services?
Yeah, there's some real issues around, I guess, equity and access and how best to provide these services in the future. I see that we're almost out of time, so we might have to wrap this conversation up in a minute. So maybe just final comments around sort of, equity and access for Bronwyn and Anna, and then, I can see comments around issues of scalability and mail services. I can imagine there's an enormous ways that these kinds of services can grow as we get the experience that we're getting now.
Yeah. Certainly mail services could be something we consider. We not, that isn't part of our service model now, but it works in Europe and people have requested it. They've phoned and I think we even had something mailed in once, but anyway, we weren't able to oblige. On John's point, I think our waiver, when I think about it, and my background's in health services as well, is similar to an informed consent, really. So I think we're very used to having informed consents in health, in terms of ensuring people do understand what what procedure they're wishing to undertake and what the limitations of that might be. So I don't really have a problem with it in that sense. Maybe it'd be better if we didn't call it a waiver.
Yeah. All right. Well, I think that might be all we have time for. So I'd really just like to say my very deep thanks to our 3 panel members today, John, Anna, and Bronwyn, and also thanks for all of the work that you're doing. I think these are really important services that we're developing and important knowledge that we're gaining, and we're obviously quite early on in this journey. So a real thanks to the hard work that you're doing to try and get these better information, both for individuals and the public, around reducing harms around drugs. So yeah, thank you very much to all of our attendees who've joined today for the excellent questions. And as I mentioned, this is our last webinar for the year, so have a safe break over the holidays, and we look forward to having our next webinars in 2023 and joining you all then.
Thanks, Suzanne. Thanks, Anna and John. Merry Christmas, everyone.
Great, thank you. Thank you to all of our speakers and our attendees.